When a patient comes into your office with a high cholesterol, they do not have a Lipitor deficiency. They came in because they're eating cheese pizza. And same thing, type 2 diabetes is not a metformin deficiency. They got there in ways that we now understand, and we can help the patients understand it and turn things around.
Welcome to the Learn Skin podcast with me, Dr. Raja.
And me, Dr. Hadar, where we discuss all things skin.
Join us as we delve into the art and science of skin health in today's episode.
Hey, Raja, can you say the thing I told you to tell them?
Of course. We are board-certified dermatologists. This podcast is meant for educational and informational purposes only and is not considered medical advice, nor does it serve as a substitute for professional care by a doctor or other qualified medical professional. All opinions shared do not express the views of Learn Health, Inc. Let's get to the good stuff.
Hey, Raja, how are you today?
Hey, Hadar, how are things going? I was just thinking maybe we need to talk a little bit more about the science of food, huh?
Oh my gosh. Well, if you know anything about me, you should know that I love food. I love to eat. I love to look for food, learn about new tastes, new flavors, new diets all the time. And definitely I have a bit of a stomach to show for it. But so do our patients. And we talk a lot in this program about food, but every now and then we get that one expert, that one person that everybody wants to hear from. And today, we have a great expert on how to incorporate food into wellness, into designing a program for your patients that can really help you. So should we introduce our guest?
Absolutely. So on the podcast today, we have Dr. Neal Barnard, and he is an adjunct professor of medicine at George Washington University School of Medicine in Washington, D.C. And he's also president of the Physicians Committee for Responsible Medicine. And I have to say, I have been such a big fan of yours just for all the research you've been doing in the area of food. And there's so much overlap to all of the conditions that we have in dermatology. So welcome to the podcast.
Well, thank you. It's a pleasure to be speaking with you today.
And so I guess I'll start with a little bit of background, because whenever we have someone who's really successful, I think it's really important to model the behavior in a way. And maybe you can tell us briefly, what got you started thinking differently, right? Because you definitely started a trend. You started looking differently at your patients, maybe at the treatment. What was it that kind of triggered that? And how did you then formalize those thoughts into action?
Well, there are quite a number of things, but one that was really influential was that there was a diabetes foundation here in the Washington, D.C. area that came to me because we were looking at a variety of research models, and they came to me and they said, we are tired of getting one grant application after another from people who want to give diabetes to rats and mice. They want to create a rat model of diabetes. They want to test some compound or other, and we don't see anything much coming from this. What would I advise? And I said, well, I would do two things. First of all, I would focus on humans, not rats. Secondly, I would focus on nutrition, because what is going to be the driver of insulin resistance and type 2 diabetes if it's not something on your plate? And so they got excited about these ideas and said, well, let's start designing some studies. So we decided to go several steps further than the diets that were commonly used for diabetes at that time. This is 20 some years ago. And we discovered that if we would make the right kinds of diet changes, you could have an enormous impact on type 2 diabetes. And I saw something that I had never seen before, which was diabetes actually just going away in participants. So in 2003, NIH gave us a grant to really put this to a good test. And we did find that you can very reliably affect insulin resistance with just simple diet changes. And so from there, we thought, well, what else will this diet do? So we started looking at effects on lipids and effects on body weight and effects on hormones and chronic pain and so forth. And it's just been a really very exciting thing, because unlike the typical medical model where the patient is rather passive, here's your prescription, take these pills. Instead, the patient is an active participant. Okay, if I eat these foods, I'm going to be in trouble. If I eat these foods, I can get on a better path. They can engage their families. It's exciting. It's life-changing. And so many patients and also practitioners have just come to see that this is why we're involved in medicine.
You know, you bring up some really interesting points. First of all, thank you for doing this sort of research, because I didn't get these lectures in medical school. And I guess maybe let me start by asking that question. Is there a lag between research and medical education, do you feel, or do you feel like there's a growing amount of interest now in this kind of nutrition? Because, you know, the lectures I got were mostly on whether you had a biotin deficiency or if you had a
Right.
deficiency in this thing, but it wasn't about how to eat right to prevent disease.
You said it. There's tremendous excitement, but there's no support for it. The medical students, when they hear that you could make diabetes go away in your patient, or that you could help somebody with clogged arteries, coronary artery disease, and you could start opening those arteries again through diet and lifestyle, that you could help patients to lose weight without having to have an injectable weight loss drug. The students love it, but their lectures are exactly what you described. Here is the chemical structure of vitamin C. Here's what to do for the next patient who comes into your office with scurvy. This doesn't happen.
Yeah, right,
So,
exactly.
Really, Roger, when was your last patient with scurvy?
Yeah, well, exactly. I'm so busy, Neal, looking for corkscrew hairs on the skin that, I don't find it all the time.
That's it. And so once doctors get into practice, many of them find that they're sort of on an assembly line. The next patient with diabetes comes in, here's your prescription. The next patient with diabetes comes in, here's your prescription. And we lose the joy of practice because we're not empowering patients. And the patients themselves don't really get a whole lot better. You're sort of fighting a losing battle. And so what we've really found is that the cause of many conditions, not every condition, but the cause of many conditions is food related. And when that's part of our treatment, it's really cool. Now, I say not everything. I mean, if a person has been in an automobile accident, they've got trauma. I mean, the answer is not asparagus at that point. They're going to need help. Or if somebody comes into your office with pneumonia, I wouldn't give them a radish. They need antibiotics. There is a role for straight ahead pharmacology and surgery and everything else that we know how to do. But when a patient comes into your office with a high cholesterol, they do not have a Lipitor deficiency. They came in because they're eating cheese pizza. And so we need to change. And same thing, type 2 diabetes is not a metformin deficiency. They got there in ways that we now understand, and we can help the patients to understand it and turn things around.
So maybe I can ask you to then go back and maybe think historically, briefly. I know it's a broad question, but where did we go wrong with the food then? Because for many years, I know, for example, Americans didn't used to eat out, and now we eat a lot out. Is it eating more processed food? Where did we go wrong as a society?
Great question. I think where we went wrong is with our legal structure. There is a law in the United States that says that our U.S. Department of Agriculture has to promote American agricultural products. They've got to do that. And so you take something like cheese and you figure out, okay, that's an American agricultural product. By law, we must promote it. And in 1909, when the USDA started tracking how much cheese Americans ate, it was 3.9 pounds per year. Really pretty pathetic. We were far behind Switzerland and France and everybody. However, the USDA found creative ways of promoting it and actually signed contracts with Wendy's and McDonald's and other fast food chains, which, by the way, I can show you the contracts. It's quite sobering to see what the government has done to put more cheese on a burger or in a burrito or some other kinds of foods. And so 3.9 pounds of cheese quickly grew to 10 and 20 and 30 and 35. And right now, your average American consumes about 37 pounds of cheese per year, which adds up to about 70,000 calories. So we can blame processed foods if we want to, but I think that's not it. I think it's specifically a meaty, cheesy diet. Exactly the diet that I grew up on as a kid in Fargo, North Dakota, not knowing any better. And where we unfortunately have been neglectful is taking a lesson from the rest of the world. There are other parts of the world where the dietary staple is rice or other grains. Maybe for economic reasons, they eat lots of vegetables. They don't eat a lot of meat or animal products, and they do dramatically better. So anyway, it's never too late to turn it around as an individual, and I think we also need to turn it around more globally as a country.
No, that's very exciting. And I think every time we hear a slightly different perspective on this, and this is excellent points, I wanted to maybe switch gears now and talk about a different aspect that relates to your work, because we hear a lot about food as medicine. We hear about carbs and fiber. I think one of the things that I wanted to ask you about is food and its effect on hormones. In your work, which major hormone pathways you found are significantly affected by our diet?
The estrogen pathways are fascinating because we have found that we can deal with endometriosis, dysmenorrhea, menopausal symptoms really surprisingly effectively. And nobody would have ever guessed that food has anything to do with estrogen. But before we get into that, I would suggest that maybe the most mind-blowing of all is that hormone that's on everybody's mind, which is insulin. And when the patient is diagnosed with diabetes, we say, well, I wouldn't eat too much sugar if I were you because you don't have enough insulin activity to keep up with it. Wrong. 20 to 30 years ago, researchers at the endocrine department at Yale discovered something absolutely life-changing for anybody with diabetes, and that was this. They brought in volunteers, put an IV in their arm, and started running a lipid infusion into their arm, fat into your veins. And what they showed is that the fat would get into the muscle cells and into the liver cells and cause insulin resistance, not over weeks, but within just hours. And they then started using oral doses of fat. And what they found was that insulin resistance actually starts out as microscopic fat particles inside your cells, fat that came from the food that you ate. And so our team said, well, wait a minute, maybe I can get the fat out. So that's got us using diets that have zero animal fat. We use entirely vegan diets, no animal products at all. So there's zero animal fat. We keep oils really low. And it's actually quite easy. And instead of meat sauce on your spaghetti, you have the tomato sauce. Instead of a meat chili, you have a bean chili. But over the next days and weeks, the fat starts coming out of the muscle cells, and that insulin resistance that had come from the fat particles stuffing the muscle cell so full that it can no longer respond to insulin, that insulin resistance goes away or it diminishes. And you see the patient needing, instead of 20 units of Lantus, they need 16, they need 14, they need 12, they need 8. They're off. You see patients where I had one of the first patients who just blew my mind, was 35 years old, had an A1C of 9.5, bad control. Adopted this diet. Within 2-3 months, he was down from 9.5 down to 7.1. And then he dropped eventually down to 5.3, threw his medicines away. And I couldn't believe that diabetes could go away. And now, this is now 2 decades later, we do this routinely in our patients. So my goal is not to manage your diabetes and slow down your amputation. My goal is to cure you. I may not get there. It depends on how long you've had the disease and how much it's destroyed your insulin-producing function. But that is always our goal.
You know, this is really fascinating. So I did have a couple follow-up questions on that. When you talk about fats, is this across the board all animal fats, or are there different gradations? And then could you also speak about maybe the vegetable sources of fat, maybe like the oils? You know, how do you build those into your diet, or do you?
Oh, yeah. First of all, yes, we do exclude all animal fats. Animal fats are very high in saturated fat, as you know, as bad fat. That's the one that raises cholesterol. It's the one that raises the risk for Alzheimer's disease, the saturated fat. The number one source is dairy, so cheese, milk, ice cream. You know, we love these things, but they don't love us back. The second biggest source is meat, and then also tropical oils like palm oil and coconut oil are loaded with those things too. So we skip those entirely. And then the other vegetable oils, aside from tropical oils, like canola oil, they're better for your heart, and they have slightly less effect on insulin resistance, but we keep them to a minimum as well. I don't mean to say that there's no oil in your diet, because if you sent a sprig of broccoli to a lab, they would tell you it's 6 or 7% fat. It's just integrated into the vegetable, and that's true of other vegetables and fruits and beans, and frankly, that's all the fat you actually need. So we work with our patients to get the fat out of their bodies, and we do that by getting it out of their diet.
Is there a difference between the quality of fat? I mean, are there, like, for example, would you say, could you comment on like red meat versus white meat versus fish? We get this question all the time. And what about avocados from the plant kingdom?
Sure. The differences between red and white meat are rather modest when it comes to insulin resistance. You really can't reverse a person's diabetes by switching them from red meat to white meat. It's just not going to happen. Chicken is fairly high in fat. When you remove the skin, you remove some of it, but even that skinless chicken breast is about 23% fat as a percentage of its calories. And then if you take fish, a big part of the drive for fish, a big part of its marketing has been that it's full of fat, but they call it good fat. So you get your Atlantic salmon at 40% fat, Chinook salmon 50% fat. And the rub is that it's not all good fat. The saturated fat content of Chinook salmon is about the same as roast beef. So all fats are mixtures, and even olive oil, way better than chicken fat. Chicken fat is 30% saturated fat. With olive oil, it's about 14. And what that means is if you're slathering olive oil all over your salad, you're packing a lot of fat into your body, and it gets into your cells. So we have to kind of break up with our love affair with Vaseline when we're thinking about our diet. And all of these foods present far more fat than our bodies are accustomed to. And frankly, the production of animals as we do it now in North America is something that our forebears never experienced. If they would go out hunting and once in a while be successful, in most cultures across the world, the diets are largely plant-based because, you don't have to sneak up on a strawberry. It sits still and you can gather them up and bring them back to your hut.
Unless you don't have a green thumb, I guess, then you do have to sneak up on them.
Yeah, exactly. And by the way, you just told 2 dermatologists to stay away from Vaseline. So kudos for you, but that's our secret weapon. You can't tell anybody that, okay? I wanted to ask you, because we talked about the micro, I want to step a little bit to the macro, another fact question. Can you talk about the differences, I guess what it means clinically, between visceral and subcutaneous fat? We hear a lot of that discussion.
Yeah, the visceral fat is really the bad actor. When the patients come in here, we will do a DEXA scan and we can quantify the fat that they have in different compartments. And yet the two do go together to a degree. Everybody is different in how they store their fat, but it's the visceral fat that's really the bad guy.
And then can you talk about, in dermatology, we have a lot of conditions where I think people really are trying to, I guess in a way, change the composition of their bodies. I mean, whether it's psoriasis or especially hidradenitis suppurativa, people are trying to lose weight, but also reduce the insulin resistance that comes up. And even in acne, we've noticed that as people take these foods that are traditionally the ones that might even make diabetes worse, we're seeing the acne getting worse too, whether it's fat intake or dairy, for example, is another big one. How do you approach the recipes that people could use, or what are the recommendations that you ask people to include? And obviously you talked about things that you might switch them away from, but what are some of your favorite inclusions that you like to talk to patients about?
Okay, but you mentioned dairy, and that's really interesting. And it's not just the fat. I mentioned that dairy is the number one source of saturated fat. That's true. But there seems to be a reaction to the protein in dairy.
Oh my gosh. Can I just jump in and say absolutely? In fact, whey protein is such a culprit for flaring acne, and the beta casein proteins too. We've done studies on sebocytes, and the beta casein and the whey proteins were not good.
I have to think that this is really the body's reaction to it. I don't know that I'd call it an allergy, but it's sort of analogous to that. And we see it with acne, you can see it with psoriasis and eczema, and you can see it with a lot of conditions, but you really never know what's going to happen until you help the patient to just avoid it completely. And for some, I have to say it's an out-and-out cure. For others, it may not be. But we do help people to get away from animal products. And by the way, we do it. It's really simple. It sounds like you've got to acquire a taste for folk music, but to adopt a vegan diet doesn't mean you have to wear tie-dye clothes. It's not difficult. The way we do it is the patient comes in, they have whatever condition it is. And we say, in addition to whatever other medical treatment we do, let's see if we can get you on a really good diet. And that takes maybe 2 or 3 minutes for the doctor to explain what it is. No animal products, we're going to keep oils low, and here's why. And then you hand the patient off to a dietitian, either in your office or you have one on call to whom you refer. And the dietitian sits down with the patient for 45 minutes, along with the patient's reluctant spouse. And you go through what they're eating in a day. And they figure out what's a plant-based breakfast, lunch, and dinner. Okay, oatmeal with cinnamon and raisins, or cornflakes with soy milk, or a bean burrito, or whatever it is they eat. And they make a list. And you ask them to take about a week to just find things they like. They're not changing their diet, they're just finding things they like. They come back after a week, they've all got lots and lots of things on their list. Now we take a 3-week period and do it all the way, 100% plant-based, very healthy, but only for 21 days. Okay, I can do that, is what the patient says. And at the end of that time, they are believers. This short time frame makes it approachable. And you meet with them every week because they'll have a problem. You call them, they either get in touch by phone or have them come in or do a Zoom or whatever. And they'll have an outside trip where there was nothing to eat at the restaurant they went to, or they didn't like it the way a recipe turned out. There's always little things. You work those out. And what you discover is that the patients adopt the diet. They wish they had done it years earlier, and they do really well that way.
I think that's really nice that you have a dietitian that's able to work with you as well.
Yes.
One of the questions I've had with plant-based diets, just as a disclosure, I am totally plant-based. I tend to be plant protein heavy plant-based just because my father actually had a history of diabetes and I want to stave that off, and I've been doing well so far. But one of the questions that we get is if you go plant-based, a lot of people end up carb loading quite a bit, or they end up eating a lot of the processed foods, like, whether it's processed breads or white flour or flour-based things. How do you approach those sort of questions, and how do you bridge that into the diet plans?
I don't worry about it very much, to tell you the truth. It depends on what the processing means. If processing means that you took a grain and you ground it up and made it into a noodle, who cares? I mean, that's okay. I mean, the worst you can say is that you may have removed the fiber if it's say white pasta, but that's not really a big thing. Processing can also mean that you're adding things to it. So you squish the corn kernel into a flake and then you add sugar and colors to it. That's not the greatest thing in the world, but it's nowhere near as bad as Velveeta or Spam or the other things that are really front and center in an American diet and that are causing insulin resistance. But what we often find is that if we start with just two rules, no animal products, keep oils really low. If that's all the patient has to do, they do really well. And then as time goes on, they start thinking through, well, what are healthier foods? And they break up with soda and some other things. And what they find is that their diets get cleaner and cleaner and cleaner. And they do really well.
That's a fascinating point, because one of the things I think a lot of people will do is they drink so much dairy and milk. So one of the underpinnings of your approach with no animal proteins and low oils is to totally cut out the dairy. Is that correct? It's not,
yes.
I mean, do you give people an option to decrease, or do you tell them, hey, you really need to cut this all out?
The patient can do whatever they want, but it's like if you're prescribing tetracycline, or let's say you're prescribing an antibiotic and it's 4 times a day or 3 times a day. I mean, they have the option to take it 1 time a day, but it's not going to.
You know what?
It's not going to help them.
I love your perspective on this, because this is exactly how I've approached it too. Doesn't mean I love it just because I agrees with me, but I appreciate that point, because I guess we have to set the boundary and the patient can decide what they want to do.
And I love how you described your approach to the patient, because you kind of read my mind. My question was about to be how you increase patients, for lack of a better word, compliance or their belief in that. And it seems like you have a pretty good system. And I like this kind of approach of a short-term goal that is manageable. And then once they get there, they're like, oh, I can do this. My question, another side of this practicality, is you mentioned nutritionist. And maybe you can tell, because let's say now I'm a dermatologist or I'm some other healthcare provider listening to this program, and you've converted me. I want to do this. Where do I find nutritionists that are actually trained and know how to work on reducing animal products, reducing fat, kind of following this diet?
Oh, wonderful question. That is actually a challenge for some people, because dietitians vary. They vary dramatically in their training and in their experience and in the diets that they follow. And I find that when I hire a dietitian, if she or he has not done a vegan diet herself or himself, they don't help patients very much, because you want them to have gone through that transition themselves. So that's the only kind of dietitian I hire. We're actually setting up a new service, which is called Preferred Dietitian Referral Program, that has dietitians in every state in the United States who are licensed to do telemedicine anywhere you might be. So if you're in Sacramento and you need a dietitian, there might be one in Berkeley or somewhere who is licensed in the state and can see your patient by telehealth that same afternoon. So that is getting set up right now. In the meanwhile, there are a lot of plant-based dietitians. It's a huge growing area. And the Academy of Nutrition and Dietetics does have a vegetarian nutrition dietary practice group that can refer you.
That's fantastic. I love the fact that we have resources to make it really easy to find these dietitians and nutritionists. I wanted to touch back on what you had talked about with the hormones. You said with estrogen and whatnot. Now, what is your approach there in terms of foods? Are there separate conditions that you're looking at in that area? If it's away from, say, the insulin diabetes story, if it's more into the other hormones, how do you approach the estrogen part of it, since you brought that up as well?
Yeah, 2 different things. At the beginning of the reproductive window in a woman's life, you will see a lot of dysmenorrhea. I'm talking about just cramps. So you've got a 16-year-old girl who's lying on the floor in the girls' room in high school because she just feels terrible. And this hits her every month. And sort of almost by mistake, we discovered that this very same diet that we're using for diabetes, low fat and plant-based, knocks out the dysmenorrhea to a remarkable degree. And I want to give some credit to researchers at Tufts who brought in 48 women, put them in their metabolic ward, tested all different diets. And what they discovered is that high fiber foods reduce estrogen. Low fat foods reduce estrogen. And that matters because if a girl has too much estrogen in her blood, it causes too much thickening of the endometrial layer of her uterus, which causes the dysmenorrhea at the end of the month. As that endometrial layer disintegrates, it releases prostaglandins that just cause this crampy pain. And it's the same thing with endometriosis. You've got the same endometrial cells, which are estrogen responsive. They are now outside the uterus, parked on your ovary, parked on your fallopian tube, or even on your intestinal tract. And with a high fiber diet or a very low fat diet, or both, you reduce the estrogenic stimulation of that. Now, we've come to figure out why the diet works, but the patient doesn't need to understand that. She just has to say, okay, I will do what you're telling me for the next 2 cycles, 8 weeks. I'm going to try this. And different women get different effects, but the effects for most are really quite dramatic. And then at the other end of the reproductive window at menopause, we just completed 2 big studies showing that the same diet plus soybeans, half a cup of cooked soybeans every day, reduces the moderate to severe hot flashes by about 88%. So it's about as powerful as HRT, but it doesn't have any bad side effects. The side effects are all good. Your cholesterol falls and you lose weight.
I love that you just talked about soy. We actually ran a pretty big study on soy protein intake, and we're looking at, how that affects the skin. But I wanted to swing back to you because there is a lot of the general public is worried about soy and its connection to potentially, breast cancer and cancer. Can you speak to that? Is that something that you are concerned about, or how do you address that?
Yeah, I'm very concerned about the fact that the public has absolutely no understanding of the science of this.
Exactly. I appreciate that. Exactly. So I wanted to get your take on it.
First of all, the concern, by the way, the reason that the Tufts researchers did these studies on diet had nothing to do with dysmenorrhea. It was about breast cancer. They wanted to tame estrogen's effect on the breast. And so what does soy do? Soy products contain isoflavones, genistein, daidzein, glycine. These are natural parts of the soy. And studies show very clearly that women consuming the most soy products have about a 30% reduction in their likelihood of breast cancer. And the earlier in life that you're doing this, the better. And in addition, we now have at least 5 studies and more than 11,000 research participants previously diagnosed with breast cancer. You can show very clearly that the more soy women consume, whether it's soy milk or edamame or whatever, the more soy they consume after a diagnosis of breast cancer, the more likely they are to live disease-free. The less likely they are to have a recurrence, the less likely they are to die of their cancer. So unfortunately, you'll go online and you'll see among all the other goofy things that are online nowadays, and it's getting crazier all the time, you will see people saying that soy causes breast cancer. Soy has estrogens in it that cause breast cancer. Precisely the opposite is true. And if you tell a woman, you've had cancer, I would avoid soy if I were you, you've just put her in the highest possible mortality group. So soy is optional. You don't have to have it, but it is strongly associated with reduced risk of breast cancer and reduced risk of breast cancer mortality. And for men, it's also associated with reduced risk of prostate cancer. So soy is a good thing. If you've got a choice of a soy-based sausage in the morning or a pork-based sausage, there's absolutely no question the soy products are the ones to invest in.
Thank you very much for clarifying this. And before we close here, just in the spirit of making small goals possible, one of the questions that I get all the time from patients is what kind of food I need to eat. And you described pretty in detail a lot of the conceptual, the diet we're striving for and what to eliminate. But I want to ask you, maybe it's a little gimmicky question, but I think it maybe help to people to kind of start wrapping their head around what it takes to follow this diet. So maybe you can list your top 3 foods that are great for your diet, and they're maybe right around the corner, but you wouldn't even thought about trying it. What are your top 3 or 4, whatever you want to list?
Okay, next door to where I am is an Italian restaurant, old classic Italian restaurant. So if I'm there, my one food there would be angel hair pasta with an arrabbiata sauce. And next to it, you can park the grilled vegetables. You can have an espresso if you want to. You could even have a glass of red wine if you like. So that's maybe number one. The other side of the street, there is a Mexican restaurant. And there I would pick either the veggie fajitas or the bean burrito. Hold the cheese, but add the jalapenos if you really want to get something out of it. And then a little bit further down the block, I'm on Wisconsin Avenue here in Washington, D.C. A little bit further down is a sushi restaurant. And I would skip the fish sushi, but have the miso soup, seaweed salad, and the cucumber roll, or the asparagus roll, one or the other of those. And what you can see I'm getting at is, if you think international, there are plenty of cultures that have sorted this out a long time ago, and they make the most delicious foods that I never got to taste when I was growing up in Fargo, North Dakota.
That's fantastic. And, Dr. Barnard, I really want to thank you for joining us today. Before we let you go, I think it's a great honor and opportunity to announce to all our listeners that Dr. Barnard is going to join us as the keynote speaker for our upcoming Integrative Dermatology Symposium. That's going to happen on October 27th to the 29th in Reno, Nevada. There's also a virtual option, but my gosh, you heard a little bit today, so I expect everybody to come in person and surround Dr. Barnard physically. Don't let him leave. Ask him all the questions you want. I'm sure he's very happy about it right now as I'm saying this. But really, what a great time talking to you, Dr. Barnard. Thank you for joining us. Thank you for your expertise. I'm sure I have so many more questions and we can do this for hours, but we do have to put a period at the end of a sentence. So thank you, and I guess I'll see you in Reno.
I'm really looking forward to it. Thank you so much.
Yeah, thank you.
Thank you so much for supporting us through the last several seasons. We love receiving your questions on social media. And now, you can call them in as well.
Yeah, exactly. So if you're a licensed medical practitioner, call us at 424-309-8757 and leave a detailed recording with your name, location, clinical question, and it may just be chosen to be answered live on the next podcast.
We look forward to your submissions. And as always, stay curious.